Thank you. Awesome meeting. Lovely discussion. See, everybody rapt attention. Um so let's hit the ground running. 41-year-old epileptic lady from Goa, uh, when asked, dislocated several times, was just not ready for surgery at all and didn't even take a consult. And each time she dislocated after a seizure, she reduced. She's had 3, 4 seizures, but she's had number of dislocations. Each time she could reduce it herself. And husband used to be very anxious, but she was very one of those personalities who was scared to go to the hospital. But recently, August, she dislocated, very trivial. She had a jerk in the bathroom and she dislocated and she was painful for a long, long time and she had to go to the hospital. And for the very first time, she had to be close reduced under anesthesia, and that kind of brought her down, and so we started investigating her. Clinically typical instability case, has been on antiepileptics for about 6 years, stable, compliant. This was her X-ray, not projecting well. One sec. We need to reduce the resolution. Anyway. So nothing extraordinary there. There was a slightly double cortical sign positive. There's a Hill-Sachs there. And that's her CT scan. You can see some glenoid bone loss, large Hill-Sachs, reported as almost 17% glenoid bone loss on the circle method. She had done that. So naturally, being epileptic, 41, we said we'll offer her an arthrolatase, and we went ahead, and it should have been a routine plan. Normally, the arthrolatase are kept at the end of the list. For some reason, because she had to be done first, we started the day with that. There were about 6, 7 cases that day, and it's very unusual for me to start with arthro. We finish off all our routine cases and then end up into arthrolatase. But I told my assistant, we are okay, we are comfortable with doing that first. Had visitors in the room, and we went in and put the scope in, and this is what we saw. So this is the X-ray, Hill-Sachs there, and then that's the CT scan. Again, Hill-Sachs, you see some glenoid bone loss, reported 17%. So we'll give it to you. We went in, arthrolatase planned, and I went in and did the rotator release and got in there, and this was a amputated coracoid. So it was only less than half the coracoid there, half the conjoint there, and that was like, this was an epileptic patient. I was like, first case of the day, didn't want to start the day this way, and just completely taken aback, wasn't planned. Sort of ticked all the check boxes, X-rays done, CT scan done, didn't anticipate that at all. So I took the phone, called the husband and said, we can't do this, and we need to go ahead and do a alternate procedure. So what should we prefer? This is your ARS question now. Now that you have a amputated coracoid, what are your options? You could take the same coracoid, half the conjoint is still attached there. You could put one single screw, it was one option. The DAS is designed for these situations where you have a subcritical bone loss and you don't want to do a latage. Or you could combine a Bankart and remplissage, or do a bone graft.
So let's use the ARS pads here.
So everybody on everything, but most of them are going for bone graft, and so we'll give it to you. I said, I called up the husband on the phone. I said, this is the situation. We have to do a bone graft, so we'll take the iliac crest. So we went ahead, and I think logically, when you do a arthrolatase with the iliac crest bone graft, you first drill the iliac crest before doing the osteotomy, put in the top hat, mark it up, and so we did the osteotomy. And the graph just split. The graph just split. Okay, switch over the screen. Switch off the screen. So we did this. That's the technique. You drill hole first. You don't cut it and then do the drill hole on the table, and the graph just split. It just split on the table just like that. So obviously very poor quality bone. She's been on anti-epileptics, and I'm like, man, this was the worst day of my life, in the sense that things could go wrong, you could salvage them, and now you're stuck. And it's a disaster. And this baby is, the husband tell me she's scared, do whatever you want. I don't want this to happen again. She's not coming to the hospital again. Because this one procedure with that, I said that's the arthrolatage because that will solve a problem. I had sold the arthrolatage so well. So now what? Okay, so partial coracoid, no iliac crest bone graft. I could do the opposite iliac crest bone graft, but likely chances are that crest of the same quality. What is the next choice? No grafts available. Open capsule plication, do a tria with the remaining coracoid, or do a glenoid osteotomy. I think Delhi guys are quite familiar with the glenoid osteotomy, and Dutch guys do a humeral derotation osteotomy in such situations. It's when Mr. Murphy visits you in theatre, where everything that can go wrong will go wrong. Okay, so favor of tria. Oh, that's interesting. There's a very recent paper, 2022, from France. They've done an arthroscopic tria. The tria was designed by the French, so only the French people do trias as such. So I called up the husband, can we switch over the screen? I said, this shit has hit the ceiling fan second time. I have no choice, but I think I'll go for an allograft. So we have an allograft. We don't have a tibial plafond allograft. We have TKR allografts and we have humeral head allografts. So I said we'll use one of the two grafts. So what was available on the ground in the freezer was a TKR. So we took a proximal tibia, a thick one, designed a 30 by 20 this thing, and used that and fixed that in. Same procedure, went ahead, and we've got it flush. It seems that the upper end tibia with its slope is designed for the glenoid because the curve matches very well. Surprisingly, this bone, after getting it into warm water and de-soothing it, was actually of a much better quality than both the coracoid and the iliac crest. So it's sitting well, it's sitting flush, and we've got a good hold on it. So we said fine. There was no labrum there to repair worth its salt, so we left it at that. And I was like, I hope this works. And then this was the post-op X-ray. This was the allograft on the table. I use only one top hat nowadays, and this was the fixation, pretty flush, pretty fixed. And now you realize what had happened. We missed out this on the axial. So we usually do a series of true AP axial striker notch view. For some reason or fate, we had done a true AP and a striker notch view, and we had not done an axial view. But we had done a CT, so the CT should have picked it up. But we failed to do that axial, and the post-op axial we came to know what was lying there. So the coracoid is somewhere down in the axilla, and that's what we missed here. So as you see, the coracoid looks good here. The coracoid looks good here. We didn't give enough importance to this, and it didn't strike us at all in retrospect. My latages take 3-4 months to recover, get their movement back. This baby at 8 weeks was just going through. So I can't explain this because she did exceedingly well. Pretty much pain-free. This was fantastic movement for arthrology. I don't know why, because the conjoint is not attached and we've just done a split in the subscap and that's gone through, or why, but this is very unusual. Usually especially the females are much more stiffer than the males. They take much longer, but she's done reasonably well. On the literature, there's very little. There's nothing on the iliac crest or the allograft. There's one Philip Morodo paper where he's compared the latage with the iliac crest versus the coracoid, and his version was that the iliac crest will fill up the defects far better, much bigger level grafts than the coracoid, but that advantage is gone after a year because a lot of that iliac crest will undergo osteolysis. So the advantage of the iliac crest is only temporary. Obviously the conjoint is not attached. In a way, it's a blessing in disguise doing a free graft in a seizure patient, because if you were to have a seizure, then the attached conjoint tendon can avulse the graft. I've had 2 patients have that in them. And then this is the Williams paper I was talking in the morning during the first session, where they've compared the cadaver study comparison between cortical button, endobutton, and the cerclage wire, and they found that the lateral displacement forces were the head of the humerus transgress out of the humerus. The screws hold much better than the cerclage, but otherwise they are pretty much equal. The only application of that paper is if you are doing a cerclage, go slow, because that micro loading or the micro motion after loading can be an issue with the cerclage tapes and things. So take home, this is the series we had done. We had no idea, we didn't suspect on this, but pre-op axial should be an important component of a pre-op screen. CT can be deceptive like this. Epileptics are always fraught with problems as such, and always having an allograft in the backup was a boon in disguise, otherwise we were in deep shit there as such. Thank you.
Sir, is there a guideline or in your experience where we should not do a Latarjet and straight away choose a idinhibinate for a primary bone loss procedure? I mean, the glenoid bone loss, is there a threshold where we should not do a Latarjet and directly choose a bigger?
So there are two perspectives that in epileptics who are unreliable and you're compelled to go in and do a Latarjet, then do a iliac crest graft. 2 of our patients stopped their anti-epileptic medicine post-op, and they had a seizure on the 4th, 5th day. If they were to have the seizure after 7 months, 8 months, which is also happened in our patients, they have dislocated the opposite shoulder. They have not dislocated the graft here because by then it's integrated. But when the graft is fresh and they have a seizure, they will avulse that graft completely. The screws will be broken inside the, Comparing the conventional Gilles Walsh Latarjet versus the congruent arc, if you have a very big bone loss, 20-25%, then use the congruent arc because it gives you a larger radius of curvature. Otherwise, use the conventional one when you are doing it a subcritical bone loss because you don't need that much height. The congruent arc matches the curvature of the glenoid far well.
But the thickness becomes,
it's much thicker, and the but whenever I've done an open Latarjet, I've always done a congruent arc. But the amount of space for your 2 screws can be a little dicey.
But you would not choose a iliac crest bone graft for a primary?
Unless that bone loss is 30%,
yes,
and that epileptic patient and unreliable patient, I have used the same technique, but you don't get the advantage of the conjoint. When a Latarjet is done, there's that triple pate effect, and in the extensive osteolysis post Latarjet, they still don't dislocate, and that's because the conjoint is still functioning very well.
But you can do ICBG and then take the tip of the coracoid and if
one
you really want
from Delhi could do it.
Sling.
Never even thought of it. It never crossed my mind.
Yeah, Ashish, Pratik here. What was the size of the coracoid that was there? Why? Because we have published on this, we have had a patient with bilateral dislocation and we have used that same coracoid first time for first side, and we were able to get away. He had a dislocation and exactly the amputated coracoid. Initially, we did not pick it up first time. When we went there, we were surprised as you were, but we were able to use the same to do the Latarjet. And then for the second side, we knew already, and we went in and do the same thing. So I was asking, and in one of the cases, we were able to put 1 screw only because it wasn't big size, but we put an anchor and tied the conjoint also there. So size, what was the size?
No, this was a 18. I need at least a 20-22.
Yeah.
Most of my ortho-Latarjet, I get a 25. But even if I get 20-22, I'm happy to put in 2 screws. But I'm very uncomfortable putting 1 screw on a Latarjet because it will rotate. And because we mobilize the patients quickly, I think on 1 screw, it's always very tenuous.
But all French people, including Phil Valenti, they have 1 screw.
No, but you could do
French
a Bristow.
That's a Bristow. They design it as a Bristow.
They've taken the same thing and put it.
They design it as a Bristow.
Yeah.
But the Latarjet guys won't.